Hey, it's the Second Opinion podcast with Dr. Paul Kolodzik, where we talk about anything and everything medical, from a sore throat to the future of AI medicine. Dr. Paul is an ER doc and certified in addiction medicine and metabolic health, as well as a best-selling Amazon author. You can learn more about Dr. Paul at his website, drpaulkolodzik.com.
Dr. Paul Kolodzik, welcome back for another episode of the Second Opinion podcast.
Great to be here, Terry.
You know, as we're heading into mid-July and now kind of seeing the beginning of early August, back to school. It's all hitting. It's all these ads are coming out, back to school.
Yeah.
It feels like summer barely got started, and they start marketing school and fall and leaves and all kinds of stuff.
You're just getting older and things go faster, Terry.
That is true.
Yeah.
Things do go faster.
Yeah.
Hey, I know you want to share a couple. Go ahead.
Well, did you hear how there's really a lot of movement in schools to get? I've had a few patients in my metabolic health clinic and addiction medicine clinics that have been teachers, and there is a big movement now to get the phones out of the schools.
Oh, I think it's state regulated now. You're not allowed to have access.
Is there? I thought it was still school district by school district.
Well, I know our school district, they don't let you have them, and I'm thrilled about it.
But there's a few studies that are now coming out that's saying that the schools that are getting the phones out of the schools, the districts that are getting the phones out of the schools, the test scores are getting better.
Well, of course.
So
why wouldn't they? They would have to.
Yeah.
It's like I get distracted by my phone 24/7.
So are you saying that the push from the technology companies to get all these tablets into the schools in the last 10 or 15 years was misguided?
No, I think that's different. The tablets can be a useful learning tool where you can learn more about history and the geography and all kinds of stuff.
As
the phone
opposed to
is a
phones.
distraction from texting and Facebook and all that crap that I think is just awful for kids.
So you're on TikTok all the time, is what you're telling me.
I am, but I'm old and I'm at the end of my lifespan, so I'm just going to go out in the blaze of glory. So you wanted to share a story that you had from a cancer patient
yesterday. So I worked a shift in the emergency department yesterday.
So go ahead.
And this is just it's just an interesting story, and it kind of ties into the theme that I mentioned on our last podcast of, I think, still caring for patients is a good calling, being a provider, whether it's a physician assistant, which my daughter's in physician assistant school now.
How long does that take?
It's going to be 2.5 years. So
she got her undergrad.
She had her undergrad.
And then she went into this, which is another 2.5 years.
Yeah. So
okay. Wow, that's great.
Yeah, it's just in the didactic portion, you don't really get into the clinical for over a year or so where you're doing rotations, but she's really enjoying it. So
that's fantastic.
Yeah. So at any rate, so I had this patient yesterday, and he was, you always identify with these patients that are about your age. So he was like a 67-year-old gentleman that had been diagnosed with lung cancer.
How long ago?
Like 5 years ago.
Okay.
So he had done really, really well.
Yeah.
In terms, so he had what's called a lobectomy, which means, the lobe of the cancer was removed, his lung. Yeah, of his lung. And then he had radiation and chemo. And he had done really well for a period of time.
And was he a smoker?
I think distant smoker. Yeah. Okay. I don't think in recent years.
Got it.
And he presented with really just kind of a mild headache and sore throat. And so in most emergency departments, there is this dichotomy that occurs that if you have a minor complaint, you go to the fast track area. Where it's the equivalent of an urgent care section in the emergency department.
Okay.
Or you go into the back with the higher acute area.
Okay.
And he was triaged into the lower acuity area. Okay. And then the physician assistant that I work with, who's great, she's unbelievable clinician, said, "Hey, I think this guy needs to come in the back." I was working in the back with the higher acuity patients. She said, he's got a bit of a headache and he's got this history of lung cancer, so I just think he needs to be checked out more thoroughly, because in the fast track, you try and order minimal tests and just get people in and out real quick.
Right.
So I said, yeah, that's fine. And I personally, just as a side anecdote, I wouldn't do well on a fast track, because if anybody has any symptoms after doing this for 35 years, it's like I immediately, go to what's the potential worst thing that could be going on.
And then you order maximum tests.
And I probably order more tests than I should order. Yeah. But by the same token, if there's any wood around here, that means, you don't miss serious things.
Sure.
So he came in the back, and I talked to him, and I agreed with her that, we ought to, patient that has a previous history of cancer and has a headache, you got to think of metastases to the brain.
Really?
Okay? Absolutely.
So that's immediately where you jump to.
Yeah, I mean, like chief complaint for the patient is headache. And then their problem list is listed lung cancer. Yeah, you have to think of that.
Wow, that scares me just thinking about it. Right?
Well, yeah, I mean, but you got to think of the worst thing moving backwards. And what's going to happen is, 99% of those people are going to have a headache that's inconsequential, isn't anything.
Yeah.
But you can't miss something serious.
Yeah, okay.
So we ordered the CAT scan.
Yeah.
And sure enough, he had brain metastases.
Oh, God.
After doing really well for 5 years, basically having a new lease on life after his initial diagnosis. So, and then, of course, I called the hematology oncologist. We didn't have to admit him to the hospital acutely, but he needed an MRI and follow-up. And, of course, they would have to coordinate an ongoing management of, whether he needed, additional radiation now to his head or chemotherapy. One thing you do when somebody has cancer in the brain, because it can create edema or swelling, you put them on steroids. So we went ahead and put him on some steroids. And then I talked to the hematology oncologist twice to get him tucked in, so that we've got this plan. He's going to get an MRI tomorrow. He's going to be on steroids. They're going to see him on Thursday. So we got everything taken care of.
But how do you break that news? Isn't it
and that's kind of the point of this story, and getting back to, a degree of satisfaction. So that is bad, tragic news. But, as a physician, I really do feel privileged to be part of people's lives in moments like that. I mean, he's by himself, he's going to, whatever you say to him, he's going to remember this for the rest of his life. And so you have to go ahead and communicate this in an honest, but honest way, but a way that still provides some hope for him.
Oh, absolutely.
Yeah.
Hope is everything. Yeah.
So I had to go back in and relate to him that it looks like that the headache is because the cancer that's in the lung that was under good control for a long period of time now looks like it is spreading. It's, and then give them hope. It's small. I've talked to the oncologist. They're going to talk about additional treatments. We're going to put you on some medicine, the steroid that should help you with your headache.
Right.
So, but again, I just feel it's kind of a privilege to be involved in people's lives in those types of moments, and hopefully take a little bit of pride in doing a good job. Again, one reason I think I have trouble giving it up. So.
Yeah, no, I mean, I think that would be a very hard thing to do. I just don't, delivering sad news, but giving them hope that just,
yeah.
You got to be good at that, right? If you're not good at that, it sounds like you are. Well,
it's like, depending upon how religious you are or whatever, it's like, the Lord has given me this opportunity to be part of this moment in this gentleman's life. So don't screw it up, and try and do a good job at it.
One thing we should do in a future podcast, I don't know how much in tune you are, but future treatments for stuff like that. Wouldn't it be interesting to do one where we talk about what's the latest and hopeful treatments?
Yeah, quite honestly, because that's chronic care.
Yeah.
A little bit out of my area of expertise, but the big news with cancer treatment is the immunologics. the bioactive pharmaceutical drugs.
Where they take your own blood and they turn it into something.
Well, there are some genetically created also. Like the big one over the last 10 years has been Keytruda.
Yeah.
Which you see the commercials on TV. Yeah. Because it's been effective for a variety of different cancers. And a number of new drugs like that are coming out. But it's one of the reasons that people that have cancer are living a lot longer than they used to.
Well, that's fantastic that it's out there. So you wanted to talk about
the electronic health record.
So we're jumping from that story to this, but I'm with you. So what is it about the electronic health record that you think folks?
So what brings this up is we're implementing a new electronic health record at the VA.
Yeah.
So the VA has had this
all
system.
VAs across the country.
Yeah. They're rolling it out incrementally at different sites, but we got rolled out on June 6th.
All right.
And first of all, it's hard to teach an old dog new tricks. It's just a challenge to learn a completely new and different system.
Oh, it has to be,
And so, our productivity in terms of, how many patients you can see per hour, et cetera, has gone way down. It's starting to come back up. But it's just a challenge. But this is similar to the medical records that they have in community hospitals as well. The most common one is a company called Epic, EPIC,
right?
And they created MyChart, which is the access that you have to.
I love it.
Yeah. So there are all these different now nuances related to electronic medical records, but one of them now. And you have it in Epic, and there's a version in our new medical record called My Healthy Vet.
Yours
is called My Chart.
Yes.
Okay, the VA's version is called My Healthy Vet.
My Healthy Vet. Meaning veteran.
Veteran,
okay.
Yeah. But part of that is that as soon as test results come back, you get them. You can get them on your phone.
Yeah, I love it.
So and that's great.
Scares the shit out of me though.
But because and then of course you go to ChatGPT and ask them what the results of your blood test means, right?
They should do that. That link should be there somewhere.
You can do that. Copy and paste it. But be careful again with and we're going to talk in a second a little bit more about this AI thing. But what's happening then is for patients in the emergency department, I'm busy, I've got 7 or 10 patients and I'm running around and I'm managing and, I'm working on, patients, 2 through 10, and then patient 1's x-ray report pops up on his phone for the x-ray that I ordered an hour ago.
Yeah.
And the radiologist has just read.
Right.
And I haven't had time to get back to him yet to discuss those results.
That's funny.
And because I'm managing the higher acuity people first. They see the results. X-ray's negative. I'm good. I'm leaving.
He just checks out on his own?
Yeah.
Just walks out.
And this is not uncommon.
Really?
My wife works in a facility that has my charts, and so people, they get the reason they came for the test, they get the results, and they leave. And I'm not talking about a high percentage, but I'm talking about an occasional person.
Right.
We'll just leave. And so that is difficult because you don't get to wrap up the visit with those people. And it can also create follow-up problems. And I'll give you an example. You can have a wrist injury where there's a certain type of fracture called a scaphoid fracture or a navicular fracture where you can have a fracture but it doesn't show up on the x-ray. Okay, like just not visible on the initial x-ray. Now you do an x-ray 2 or 3 weeks later when the healing process has taken place and calcium is being laid down along the fracture line, then you can get it. So the standard treatment for that is, put somebody in a splint, leave the splint on for 2 or 3 weeks, get a repeat film, and make sure that healing process isn't evident. So things like that can be missed when people just, look X-ray's negative, I'm good, I'm taking off.
Oh.
So that'll be a challenge for us. Because
I sometimes you get your blood work done, and on the ride back, your phone dings. It's just like, there's the results.
Yeah.
And then you go and look at them, and they give you that little meter that either you're good or bad, kind of like there's a little arrow pointing downward.
Right.
And you just hope it's in the middle all the time.
In the green.
In the green.
Yeah. So, a lot going on in terms of the electronic health records. I think we've talked, you and I have talked personally about the ambient listening thing.
Yeah.
Which is, in some facilities, the doctor can bring in a device that listens to the conversation, and then that helps the doctor, when they leave, go and create the medical record, because that information is recorded and then organized by AI into the standard components, which is what's the patient's chief complaint, what's their history of present illness, what's going on over the last few days that brought them in, what other symptoms they have, called the review of systems, then the physical exam. So that all gets recorded. So the good side of that is, maybe the doctor's not going to have his face in the computer as much and going to be looking at you.
Oh, I agree.
Yeah.
Yeah.
But then that information needs to be reviewed carefully and then organized. And what is now going on with many of the newer electronic health records is, at the end of that visit, we always come up with what's called a differential diagnosis.
A game plan?
You start with a differential diagnosis. So, for example, is that gentleman's headache due to a migraine, or is it due to a stroke, or is it due to metastases from his tumor? What's the differential? What are the different considerations?
Right.
Okay. And then you assess that, pick one of those, and then put a plan together. So AI is helping create those differential diagnostic lists, which may be good because it might be something the doctor didn't think of or might have missed.
Oh, I think it'd be good.
Yeah. But it can make you chase your tail too, because it can make you put things will come up on that list that will then, require you then maybe to order another test.
Oh.
So there's a balance there.
But I do agree. I mean, I love my new doctor. She's fantastic. But she's quick typer. I'll give her that.
Yeah.
And she gets things down pretty well when I see the notes from the visit in my chart.
Yeah.
But wouldn't it be great if she just didn't have to do that?
So, next time you go in, why don't you say, hey, doc, have you tried any ambient listening approaches? That's the term that's used.
Do you think they're all familiar with that term, or is it?
I think most docs are aware of it.
Okay.
And some, I think, have the option to use it and choose not to use it.
Right.
We don't have the option in my facility to use it or not.
All right. So is there anything left that we want to chat about?
No, just that we'll focus on this in another session. I told you, I think just in conversation a few weeks ago, that the way these AI models are created is from what they call expert input. The term that's used is annotation. ANNOTATION. And what that annotation means is that for medicine, a clinical scenario is created, and then AI, so I'm learning about this now, AI comes up with two different responses. Okay? Patient has history of lung cancer and a headache, and AI comes up with two different approaches to how it should be worked up, the test that should be ordered, and how this should be managed.
Right.
Okay. And then the annotator, which is, the quote expert that's looking at this, says, this one's right and this one's wrong. And that's how AI builds its model over time. So that's what a lot of these AI companies in medicine are doing right now. They're building models based on expert input.
Do you think there'll be an AI doctor someday where basically you go get your blood work done, it gets fed into an AI engine, then you have a little chat with the AI, like we did this morning with our AI attendant on a
on the website.
Right?
Yeah.
Do you think it'll come to that?
My hope is not, but I think it's a possibility for certain categories of problems. I think if it's a minor problem, that's possible. So,
do you ever think there'll be an AI AI being able to issue a prescription.
Yeah, actually, there's been some discussion of that in some states because, medicine is state regulated.
Yeah.
Okay. And actually, I saw this 6 months ago. The issue was, the state was Utah, and it had to do with refills of medications, not new prescriptions,
right,
but refills. And the issue was, in rural areas, there's a shortage of doctors, and they did, based on an AI review of medical records, allow certain prescriptions to be refilled for a limited period of time. So
that's great, because normally when you refills out, we're going to contact your doctor for you.
Yeah.
And sometimes they get here back and sometimes they don't.
Yeah. So I think long term, in some discrete limited areas, that will probably happen. I think for more complicated cases, it'd be more difficult, and you need that interaction, like the patient we talked about at the beginning of this podcast. I don't see how AI could manage or that I don't think people would want AI to manage that. I think
you need you don't want AI.
They want a human they can trust.
Well, you wouldn't want an AI guy to come in and tell you the bad news.
Yeah.
Right. That has to be something that has to be human to human.
So this will evolve over time, but with the stuff AI is doing, like your drone show on July 4th. I mean, that's just, that synchrony was amazing. So
it's crazy.
Yeah, it's a new world. So I will talk about it on a future podcast.
Yeah.
I'm dipping my toe in the expert analysis annotation thing.
Yeah.
Providing some input for some AI companies, just because I'm interested in this area.
Well, I produce music for this other side of my business, and using AI to produce music is just, oh my gosh, it's just
how much it's changed things.
It's changed things.
Yeah.
So I'll bring that topic up because I think people would be fascinated a little bit by AI in the music. Maybe.
Yeah.
So it's not totally medical, but it is fun to talk about.
Yeah. Because when I listen to, a song from your youth, it's like you listen to that and you say, AI can't ever recreate that. And I hope I'm right.
You're wrong.
Okay.
Hey, folks, thanks for joining us on the Second Opinion Podcast with Dr. Paul Kolodzik. We'll be back again real soon with another fun-filled episode. Thanks.